Thank you for staying till 2 p.m. after the first two outstanding speakers. As you can see from the previous talk, there are some common themes, which means if you want to do any kind of intervention for seniors, the themes are: how do we maintain well-being, security, independence, comfort, and especially safety. And the same theme is going to go through my talk, which means any behavior that a senior exhibits, if it is not compromising any of this, safety, security, independence, there may be no need to start putting some interventions, because we need to recognize the heterogeneity of human personality and human behaviors. So we don't pathologize every single deviation from our expectation as disease. So at the end of this talk, we should all be able to know what kind of behavioral problems in old age and what lead to them. More importantly for this talk is about how do we manage the behavior, with a lot of emphasis on non-pharmacologic treatments. Now, the emphasis here is on problematic behavior, because if any behavior is not compromising safety, quality of life, independence, you don't necessarily have to medicate it. It could just be a variation of normal human behavior. So, however, these are examples as listed in what they call neuropsychiatric inventory. Is a document, is an inventory of all sort of behavioral problems and issues that you give to people. And as you can see here, apathy, social withdrawal, agitation, irritability, psychosis, which is a combination of paranoia, delusion, and hallucination. Euphoria is actually listed here, which means to be happy, out of context. Now, a lot of this behavior by themselves may need some kind of therapy because they are just obviously dangerous. Aggressive behavior, a patient that is threatening to kill himself or herself. But again, we have to put all this in context of, is this behavior compromising safety, independence, quality of life, and security? And I'm sorry I'm repeating myself, but I want to make sure we don't always turn a different variation of behavior into disease, which is one of the reasons we have a lot of iatrogenesis, healthcare-induced problems. So, I think I've gone past, okay. Now, some of the terminologies here are very clear to all of us. The concept of delirium, which is acute change in behavior, is something that we've all seen, from physical therapy to social worker to MP and MDs and PAs. And as we all know, the key to managing acute change in mental status, which is called delirium, is to look for the underlying medical illnesses. Many times you will find several. Is it infection? Is it a manifestation of new congestive heart failure? Is it untreated pain? And that is well known. And that is the obvious focus. The second thing we should also focus on is to recognize that both acute change in behavior, aka delirium, or chronic behavioral problems could also be a manifestation of drug toxicity. And in this case, alcohol misuse. There are so many examples of drug toxicity. For instance, corticosteroids used for treatment of so many conditions, COPD, gout sometimes, could precipitate psychotic reactions. Sometimes people want to go abroad and they need malaria prophylaxis, and you give them mefloquine, and they can precipitate florid hallucination psychosis. But the most common example of drugs, even at normal doses that can cause behavioral problems, are medicines for Parkinsonism or for Parkinson's disease. Sinemet is a good example. Some of the direct dopamine agonists, such as pramipexole, can cause a lot of impulse control problems. Now, when it comes to alcohol, That's the whole topic. But the one that, apart from withdrawal from alcoholic addiction, but there's also some constellation of syndromes that manifest as behavioral disorder. One of them is called Wernicke syndrome, whereby people who take alcohol chronically, they experience depletion of thiamine, vitamin B1, and they can result into a lot of disorientation, psychosis, ataxia, and so on and so forth. So it's important to recognize that. Now, the other drugs are listed here. I put them there because it doesn't mean we shouldn't use those drugs. Medication that can cause depression, another symptom of depression. Is to recognize that if you have a patient showing depressive symptoms or suicidal ideations, and they're on this medication, they could be contributing to them. Montelukast singular is people use in the context of allergic diseases. Chantix is a medicine recommended for smoking cessation. Of course, clonidine is a blood pressure medicine. And interferon alpha sometimes used in treatment of chronic hepatitis C. So these are medications we do know can precipitate depression in people who are already predisposed. But for this talk, which is the context of geriatrics, you cannot talk of behavioral problems without talking of dementia. And as we all know, dementia is when you have problems with memory and other cognitive area to the extent that it affects your day-to-day function. There are many causes of dementia. Some of them are treatable. Most of them are not treatable. But the main ones that have a prominence of behavioral problems are Lewy body dementia, Alzheimer's disease itself, and an entity called frontotemporal dementia. There is a lot of behavioral complications and psychiatric symptoms that are part and parcel of this syndrome. So we're going to talk a little bit more about them. Then, when you're talking of behavioral problems in the elderly, you also have to think of primary psychiatric diagnosis. First of all, diagnoses that have been there since younger age. And then there are development of other problems, late life bipolar, depression, anxiety disorder, schizophrenia. But more important is exacerbation of personality disorder traits in the face of stress. And you see that a lot. For instance, if one of Dr. McGregor's patients happened to suffer from narcissistic personality disorder, that would be very tough to convince. These are people who have an incredible sense of entitlement. And but most of these patients with personality disorder, they tend to experience what you might call catastrophic reaction, particularly when they face stress or loss. So one has to recognize that. As physicians or as clinicians, the way I recognize personality disorder sometimes when you have a patient that before you go to see that patient almost always makes you angry or upset or feel incompetent. You have to keep on asking yourself, is there a personality disorder trait here? The other one we should recognize is post-traumatic stress disorder, particularly among veterans, but that can also occur in the context of abuse, either spousal abuse or elder abuse. And it could manifest in different kind of behavioral problems. So this slide more or less tells us that when we have any seniors showing agitation or aggressive behavior, any behavior that is compromising safety, well-being, independence, security, we should always think of potential underlying reason and not just to jump into treatment. Now, this is when we're going to do some, I hope, we can't do it here. We can't do it here. Part of it is because I replaced that with elderly people. Anyway, I'm asking this question here simply because if you're a senior, somebody in their 70s or 80s, comes to you, whether it's physical therapy office or physician assistant or MD or MP, and they have symptoms of paranoia, delusion, hallucinations. What is the most common cause of psychosis in the elderly? That's the question. Well, there's no doubt a subset of people with depression can manifest with a lot of paranoia, and sometimes you can even have hallucination. Of course, alcoholism can, whether it's withdrawal or whether they have alcoholic intoxication. Late-life bipolar disorder, of course, they can manifest to also as psychosis. But in terms of the prevalence of each of these conditions, what do you think is likely to cause to be the answer? Alzheimer's disease. Yes, in fact, if you have any senior that the first time they are coming to you, the constellation of hallucinations, belief that is not true, delusion, or paranoia, there are many causes of that, but on top of your list is to screen for possibility of Alzheimer's dementia. Yes, bipolar disorder can cause it. Drug toxicity, it could be a manifestation of schizophrenia or alcoholism or depression. And let me show you this slide. This is a study that actually has the question, look at patient presenting to the clinic in St. Louis, Missouri on day 0. And then they ask the relatives about presence of symptoms over the last 2 to 3 years. And what we see right here is that about almost 3 years before presentation to the clinic where dementia was diagnosed, the patient was already showing evidence of social withdrawal and depression, paranoia, change in sleep pattern, anxiety. And about the time patient visited the clinic, then you have a lot of irritability and so on and so forth. And what you notice is as the disease progresses, you will have more of the more serious behavioral problems. So the point of this slide is when you have a patient presented to you with this constellation of symptoms, there are many causes, but you need to think that of the possibility that could this be a leading indicator or a warning sign of an underlying undiagnosed dementing illness. And as you will see next slide here, a lot of these behavioral symptoms that you have, they tend to be much more prominent as the dementia severity progresses, to the extent that agitation is 85%, and aberrant mental behavior, meaning wandering and pacing, is about 84%. Now, and then you see delusions and so on and so forth. The only thing that decreases with the progression really is hallucinations at the late stage. So it's important to recognize that in the elderly, people in their 70s and 80s and 90s, when you have psychosis, on top of your mind should be, could this be possibility of dementia? It could be, there could be other reasons. It could be side effect of Parkinson's drugs. It could be somebody with chronic schizophrenia. Now, let's move on to this question. I think this one, does he have it? No. Okay. This is, as you can see here, a 91-year-old man was found wandering during a Mardi Gras party last weekend in Galveston. And he was brought to the ER. Prior medical record documents alcohol dependence. Physical exam showed disorientation, nystagmus, reduced peripheral sensation, a staggering gait. What diagnosis best explain the behavioral and neurologic changes in this patient? Is this patient drunk, alcohol intoxication, Korsakoff syndrome, Wernicke encephalopathy, dementia associated with Parkinson's disease, depression, severe hypothyroidism? What do you think is going on? This is a very elderly man. Was just found wandering in front of, in the Strand. Remember, the patient has psychosis, ophthalmoplegia, ataxia, is a known alcoholic, and this is an acute change for these patients. Well, anyway, the answer actually is one. Oh, this thing is not going forward this time around. Maybe you can help me. Oh, yes. Korsakoff syndrome is more of a chronic, it's a chronic consequence of alcohol, excessive use of alcohol. And in this situation, you've already damaged most of the temporal lobes. And there is the key symptom in Korsakoff syndrome is just anterograde and retrograde memory loss. So somebody with Korsakoff syndrome will have, I want to say we'll give this talk, but after giving this talk, we'll have absolutely no idea that they actually hear. However, they can tell you all the poems and books they've read 10 years ago, and it's a chronic, stable thing. But Wanix is more of the acute complication of chronic alcohol use, whereby the thiamine deficiency has caused a lot of damage to several parts of the brain that controls the cerebellum, the area surrounding the third and fourth ventricles. So it's actually it's a potentially lethal disease unless you admit the patient to the hospital and give them infusion of thiamine. If I must say, you can find Wanix encephalopathy also in other conditions. It's not just alcohol. Any condition that thiamine deficiency can happen. People with anorexia nervosa, for instance. People with malnutrition, and you are feeding them rapidly with glucose. So, now, all this can also cause behavioral problems, alcohol intoxication, depression, but there is no history suggestive of all this in the presentation. Now, this is another case of behavioral problem. This is a case of a 62-year-old woman in clinic with her daughter, and the chief complaint is odd behavior of 2 years duration. And the behaviors are described as, we eat full boxes of marshmallow, chocolates, and cookies all at one sitting, giggling, make rude comments to strangers. And when they will go to friend's house, she will pull out the drawers, can even look at the bills and say, "Hey, Tony, I can't believe you owe $10,000 on your Visa card," or something like that. And she would laugh inappropriately. We'll go to a funeral service and we'll just be laughing at everybody. The MMSC was 26/30, and the clock draw is normal. And the MRI shows atrophy, particularly prominent in the frontal area, right greater than left. The question is, a patient with mild impairment of the MSC, but with prominent behavioral problems, relatively young patients, what's the most likely cause of this odd behavior in these patients? So this is the time you will use the pointer.
So get your keypads. A
is 1.
B, C, D. Ready? Oh, it's got 20 seconds. See, use it.
It tells you receive.
Right. When you hit send, it should say receive. And we got to find a 20-second music clip. We're getting there. We're working on it.
Okay.
All right, don't worry about that.
Okay.
There we go.
Yes. Oh. Well, this is good because at least it shows that. Well, the reason why it's not Parkinson's disease is, first of all, there is really no history given to you of the bradykinesia, of falls, of tremors. But yes, behavioral problem can happen. In fact, 40% of people with Parkinson's might develop dementia and eventually might develop behavioral problems. But behavioral problems in Parkinson's tend to be more of a side effect of the medications. A lot of the medication like Sinemet and so on and so forth can precipitate hallucinations, but not this kind of impulse control disorders. Yes, Alzheimer's disease too can do that, but the age of the patient is a little bit against this, but it is supposed to have Alzheimer's in your 60s. But more important here is the finding on the MRI, which is prominent atrophy of the frontal lobe in this. And by the time Alzheimer's patient develops such behavioral problems, the MMSE is usually almost in the single digit. The dementia tend to be a little much more advanced. Now, Lewy bodies could have been the answer, except that, first of all, we didn't give the history common with Lewy body dementia, whereby you tend to have dementia as well as presence of prominent hallucinations and some element of Parkinsonism. So this is not here. Yes, depression can cause behavioral problems, but not in this kind of context of severe inability to control impulse. So the answer is frontotemporal dementia. Generally speaking, a lot of patients with frontotemporal dementia, they ended up with in psychiatric. Part of it is the behavioral problems sometimes cause a lot of relationship problems. This kind of patient, when they drive, if you cut them off, they may actually pursue you to shoot you, because what happens is the higher cortical control of impulse is inhibited. It's almost as if they have alcohol intoxication. So whatever comes to their mind is what they will say. And it's very difficult to treat. And they have very poor insight into what is going on. Okay. So anyway, all these examples are just to make one point, which is when you have patients showing problematic behavior, the approach to treatment is to do everything you can, history-wise, physical exam and test, to look for the underlying causes. If it's acute change in mental status, you look for medical illnesses that can cause delirium. Drugs that may be contributing to the behavior needs to be removed. But more important is the effort should be based on using non-pharmacologic approach. Now, if a patient is imminently about to cause problem with safety or security, there may be indication to use psychotropic agent on a short term. But it's important to recognize that there's no need to treat any behavior that is not dangerous. Sometimes you have patient on the inpatient service that may be, describing hallucination of hearing songs or seeing little children playing around. If that patient does not experience psychic anxiety, is not distressed, and only the clinicians who are worried, there's no indication to put the patient on antipsychotic. So it is important to put this in mind, because one of the reasons for polypharmacy is for clinicians putting drugs to treat behavior or symptoms that have no consequence on the patient. So let's move on to the next question. A 94-year-old nursing home patient with Alzheimer's dementia is evaluated because she has been disturbing other patients by screaming for help and banging on her recliner throughout the day for the past 4 weeks. Which of the following is most likely to reduce the patient's agitation?
Ready?
Well, this is better. 2/3. Well, non-pharmacology, because it's important to recognize this patient, has problem with communication and is on a recliner every day. It's obviously easy for the people working in nursing home, and patient is just screaming, "I'm tired, I'm bored, I'm hungry." It could be a number of things. So if they call you as the clinician, I think it's to think of a number of what one can do. And I want your input on this. What kind of non-drug, because the other 3 answers are drug, can one do in this particular patient who is always in a recliner and screaming? There's really no wrong answer. Just think about somebody tying your mouth down and you're just lying down there. What kind of intervention can one do in this situation?
Music?
Music, that's one. It could just be boredom. Reading. The patient.
Asking them if they're hungry or thirsty.
Exactly, looking for bodily needs. Do you want to go for a walk? Do you want a drink? Maybe the patient actually may have back pain from the recliner that is all. So it may just be a way of communicating needs that the patient with dementia or stroke may not be able to express. Now, using all these, treating depression or using antipsychotic agents like risperidone or Aricept, anticholine, it's not going to make a lot of difference. If anything, all antipsychotic agents in studies upon study have been shown to increase your risk of mortality, metabolic syndrome, and death. So, and sometimes antipsychotic can even cause what they call paradoxical restlessness, akathisia. So, it is important to recognize that you always want to explore non-drug approach in treating behavioral problems. So, the need to express basic needs, hunger, thirst, fatigue, which the patient with stroke or dementia may not be able to say, may actually cause a behavioral disturbance. So using drug is not going to be able to treat this. Now, the concept of agitation, which is basically reflecting loss of ability to express behavior, could manifest as physical aggression, especially resistant to bathing and other care needs, restless motor activities such as pacing or rocking. And many of these behaviors, sometimes, particularly in dementia, may occur within the presence of paranoia, delusion, or hallucinations. In Alzheimer's dementia, the delusions in Alzheimer's dementia are understandable in the sense that it's part and parcel of not remembering. So the patient might not remember where he or she put something, and they will believe that somebody has stolen it. The patient might believe that the caregiver, the wife or the husband, might be a stranger, and he or she will be shocked that this person is trying to dress me, and the person is just going to say, I don't want this stranger doing this to me. So this is different from the delusion you find in some of the primary psychiatric diagnoses, such as schizophrenia, which tend to be bizarre without any connection to reality. So when you have a patient showing behavioral problems, agitation, aggression, or any behavior that compromises safety, the first thing is to get a history, not just from the patient, but from a caregiver or somebody who can give you an idea of the temporal and cause of the event, circumstances related to the event. Does it happen only when patient wants to take shower? And any connection to environmental factors, such as particular caregiver or particular recent stressor. I was at a GSA meeting last year, and there were a few nursing homes that what they do in that nursing home is to ask the CNAs, the certified nursing assistants, to make a list of the patient they would prefer to take care of. And they also tell the patient too, who can still communicate, to kind of indicate the CNA they would prefer. And then they match them together, and they were able to see improvements in the rate of agitation, in the quality of life of these patients. So the wrong caregiver can sometimes, or caregiver that is overbearing or very rigid, can precipitate some of these behavioral problems. So, as you can see here, the causes of medical, environmental, as well as when you have a rigid or inexperienced. As a matter of fact, the caregivers themselves may also be at the stage of developing dementia. And there was an article in the Newsweek magazine a few years ago whereby it's a case of husband and wife who both developed dementia at the same time. And the article was written by the daughter, who is a middle-aged woman who wrote the article. And the title of the article is, "In Their Loss, They Find Each Other." In this particular article, this couple, over 40 or so years of their marriage, they were always butting heads together. But as they both develop dementia, they become the best friends, simply because they always forget, whatever is it that they should be fighting about. It's a very interesting article in the Newsweek magazine. Now, so what we then do, we should also not forget about the caregivers, which is the theme for the first talk by Andrea. Safety of the patient, driving, cooking, patient getting lost, one has to pay attention to that. But more important is that we should avoid potentially harmful interventions. Interventions that I believe we should always explore first are the non-drug intervention. And that include distracting the patient, validating patients who have dementia, redirection, supervision, and as Tony mentioned, music and physical therapy. Sometimes aromatherapy has been shown to help. So we're going to do a lot of exercises to show some of these behavioral activities that you can use in improving behavior. Physical restraint is not a mode of medical care. It's been shown to lead to more problems, to actually cause depression, bed sore. And physical restraint just doesn't mean tying patient down. It also involves not discontinue things like Foley catheter, nasal cannula, or any other tubes or IV that patient no longer need. So for the next few slides, we're all going to practice some distraction, validation, and redirection techniques. So this is what I prefer instead of putting the patient on haloperidol. So these are the examples. And this example is taken from Care Advantage Journal. So let's start, and there's really no correct answer. What matters here is more of, do we, is instead of putting this patient on antipsychotic medicine because of this paranoia, and instead of saying, so during meals, your father refuses to eat, and he says, you are trying to poison me. Instead of saying, that is ridiculous, why will I ever do such a thing? Eat your meal and start making a fuss or making up crazy stories. How do you think, I can tell you, if you say this to him, what do you think is going to happen? He might actually throw the meal and actually. So instead of saying this, what do you think one can say? This is the 92-year-old man who is actually losing weight, and you're trying to convince him that, look, I'm not trying to poison you. Please, this is a nice meal. And he said, no, you are trying to kill me. I know you're interested in my life insurance. So how do you think one can handle this? Using any of the techniques that you've used in the past.
Oh, go ahead.
Do we tie him down and force feed him?
Dad, I worked on making your favorite meal all day long, and Joey's eating this. Why don't we join Joey and eat this nice dinner?
First of all, in a way, you redirected him to think about Joey. I assume Joey is a favorite son. Not yes, or friend. Any other approach?
Ask him why they think they're trying to poison him.
Yeah, you can engage him. I don't think one would want to validate this. But yes, I'm trying to kill you. No. You can engage, experience. In fact, that is the title of one of the schools participating: experience, engage, and explore. I don't know which of the university is that. Anyway, what she suggested, Susan London, is that, you might try, explaining, I understand you are feeling afraid. I want you to know I would never let anything happen to you. You are safe with me. And then that's it. By the way, this is the best meal, in Galveston. I am having a big plate myself. which is equal to Joe. I'm not going to kill Joe and myself. And then I'm going to, that's the best. And I'm going to have a taste of this. You can tell me, and then you direct to fishing trip. Now, who knows whether this is going to work, but it's certainly better than saying, what do you mean? I'm not trying to poison you. So let's do this one. This one, your sister with dementia.
The other sides can unmute if they want to.
Oh, okay. I see.
Yeah, just ask them they could unmute.
All right. Okay. You stole my money. Give it back to me. And then you tell your sister, I'm sick and tired of you accusing me every time you had your money. You stuffed it in your drawer 5 minutes ago. I saw you do it, so stop blaming me. The other side, how do you think we can respond to this? One approach will be, of course, we are not going to put the patient on medication. What would be the best or a less antagonistic way of responding to the sister? Anyway, yes.
I can say, sister, probably you might have left it somewhere and forgotten. Why don't we look where you have left it around the house, and maybe we can find it, your money?
Yes, that's good. Because you are validating, because validating stolen money, it's not like validating poisoning. Any other approach?
I'd like to make a brief comment. I think these suggestions are wonderful for someone maybe who's mildly demented, but once you get to severely demented, you may have to try to put not exact validation, but a little bit of validation there, if you know what I mean, and kind of work with them from their storyline.
Exactly, I agree with you. For example, yes, you are validating them. That, look, you are not arguing with them. You are basically saying, yes, your money is missing. There are probably thieves going around this house. I can see why you're upset. So, well, don't worry, because I'm going to help you look for it. Sometimes people, even when it comes to reading glasses, the patient will always look around, and some people will have several reading glasses, one of those inexpensive ones around, and they can actually validate the fact that somebody has taken it, and they look around and they find it. So now, this kind of behavioral technique, there aren't fixed approaches to it. It's all about recognizing that if somebody has delusion in the context of dementia, arguing and trying to reason along logical lines may not always resolve it. But redirecting their attention, validating what they are saying, if it is not dangerous, might actually help in diffusing tension. Because what tends to happen is people will try to butt head with patients with dementia, and it can lead to other catastrophic reaction. And it's not going to help in this kind of situation. I think there's another one more example. This is a patient with dementia, the grandmother with dementia, who somehow believe that the kids are still in their 20s or in their teenage years. So I have to leave right now. I need to pick up Jimmy from school. Jimmy happened to be, an attending at UTMB. And then instead of saying, Grandma, Jimmy is a grown man. He's 60-year-old, you're not going anywhere. Now, using the same technique, how do you think might be a good way, or should I say less, antagonistic way of handling this problem?
Let them know that somebody
I've already
else is going to
picked
pick
them up.
them up.
Yes, that's one. Somebody else is picking him up. Yeah, sure. Jimmy is in 3rd grade, and I've told Susan to pick him up or something like that. That's a good one.
Somebody said something.
Yeah, what did you say? At
I would probably say what she said. Someone already picked them up, or I would probably say, well, maybe we can go for a ride and see if Jimmy's still there.
That is good. That's a good example. Somebody say, let's go for a ride and look for Jimmy and go get him from school. And hopefully she will have forgotten our Jimmy, because if you keep on driving and say, why is Jimmy? Then you could go into another problem. But I hope the patient will have forgotten that Jimmy is no longer in middle school. Any other comment from the audience? Yes, similar to that. Yes. Well, this one is you've always been such a loving mother to Jimmy. Why don't you come? This one is more of trying to take the attention away and tell me what you love to do after Jimmy is back from school. I think the last example. Okay, great. I think this is the last one. Your uncle believes he's still at work. Your uncle with dementia. He treats you like an employee, even though you are taking care of all his ideas, and tell you you need to finish these assignments by the end of the hour in a very stern way. And then you tell him, say, look, are you starting with that nonsense again? You retired in 1985. How many times do I have to keep reminding you that you are no more, at your work? So how do we handle this? When your uncle... Any suggestion?
Let him know you're going to finish it.
Exactly. You are going to say, yeah, that's one.
Gain his help in finishing it.
Yes. It's too, I need somebody, with better skills to help me out so that I can... Any comment from the other sides?
I usually tell them something like, you told me you were going to give me 2 hours.
Yeah. That is great. Mm. Yeah. Yes. She suggested saying, you really run a tight ship around here, and that's what makes you a good boss. I'll make sure to get the work done to you, but I will need some little help. Can you assist me with one of the documents? Hopefully you have some fake documents going around the house, So, if all I've achieved in this talk is to emphasize that before you jump to medications, you want to look for what are the issues, both medical and environmental reasons. And before you jump to the medication, try non-pharmacologic approach. Try to put yourself in the shoes of this patient who may have stroke or dementia or other problems that is impairing their ability to communicate their needs, from pain to hunger. Now, there will be situations whereby the problems require medications because they are parts of the underlying problems. And in that situation, let's see. For instance, when you have persistent behavioral problem, despite all your non-pharmacology behavioral intervention, particularly in the context of dementia, what I tend to do after exhausting, looking for infection, looking for pain, but there will be many cases whereby none of those are contributing. Your pharmacologic validation, you've exhausted it. And what I tend to do in the memory loss clinic is to look at the behavior in these 3 contexts and ask myself, is this behavior falling into the context of delusion and hallucination, which is called psychosis? And if that is so, I may want to choose an antipsychotic agent to help improve this psychotic behavior. But I will only use any of these agents, quetiapine, aripiprazole, or risperidone, only again if these psychosis, delusion, and hallucinations have effect on the safety, well-being, independence, and quality of life of the patients. And the same thing goes for mood symptoms. If the manifestation of behavior seems to fall more into the area of depression, it's very difficult to diagnose depression in the context of dementia. Then in that situation, I would try to use any of the SSRIs, or serotonin, noradrenaline reuptake inhibitor, or noradrenergic and serotonin antagonists like mirtazapine. But many times, the behavior will form into what you call manic-like behavior, almost bipolar-like. Now, these are very soft classification, but they allow you to be able to choose what pharmacologic agent to use. And in this situation, you want to use mood stabilizers such as Depakote or lamotrigine, which is called Lamictal. Or sometimes you may want to use Seroquel, quetiapine. Again, if you are not experienced with this constellation of symptoms, it's a good idea to refer such patient to either a geriatrician or to a psychiatrist, because this requires a good knowledge of psychotropic agents. Now, let's look at an example whereby we're going to do, I don't know, does this one or it doesn't? Yes. This is a 92-year-old woman with dementia, Alzheimer's dementia, who came to your office with her daughter, and the daughter has been complaining about increasing aggression toward his wife and the home health aide. The daughter is worried about safety and asks that he be given medication to control his aggression. I must say that you've tried all around pharmacologic approaches. You've looked for environmental causes, you've looked for pain and everything. And then the discussion now move on to different psychotropic medications. And then the doctor is asking you about side effects. Which of the following are associated with increased mortality in the context of dementia? Yes. Well, I was expecting 100%. First of all, the correct answer is antipsychotic agents. The Food and Drug Administration never really approved antipsychotic agents in the context of dementia, but they are widely used. In fact, there was a recent publication whereby people tried to stop it, use of this medicine, and there was a huge recurrence of agitation and behavioral problems in the patients that experienced discontinuation. However, when you look at antipsychotic agents like Haldol, haloperidol, or risperidone, and quetiapine, whether it's the first or second generation, they've been associated with increase in the risk of mortality, extrapyramidal symptoms, as well as metabolic syndrome. I have to say that they all have different risk of all these side effects, especially when it comes to extrapyramidal syndromes like Parkinsonism. But they are all associated with increased risk of mortality, independent of dementia itself. That doesn't mean you won't use it, but you just have to explain to the daughter, who happens to be the caregiver here. Antidepressant agents really has not been shown to increase mortality because depression itself is a potentially lethal condition. What has been shown with antidepressant agent is about 6 to 8 weeks of people being started on antidepressants. A subgroup of patients might experience increased risk of suicidal thoughts and suicidal attempts, because that may be the time they now have the energy to want to go ahead. So it's more of a manifestation of the pathology. But the FDA still requires in the drug inserts for clinician and patient to watch out for emergence of suicidal ideation in the 6 to 8 weeks. Mood stabilizers not. Anticholinergic agents have not been associated with increased mortality. We are talking about Aricept, Excelons, and Reminil. So the answer is antipsychotic agents. The reason why I brought this up is antipsychotic agents are not benign. You need to always let your patient know about the risk benefits associated with this agent. So the summary of my talk is, when a senior shows any behavioral problems, whether in the context of dementia or stroke, it may represent the need to experience basic needs such as hunger or pain, which the patient cannot adequately communicate. And when seniors experience certain changes in behavior or mental status, which is called delirium, we should always look for and treat underlying conditions such as UTI, dehydration, or drug toxicity. And we should always try non-pharmacologic approach first, both environmental modifications and several behavioral approaches before we jump to medications. If behavior poses danger or compromises safety, short-term use of psychotropic is appropriate. There is no need to treat behavior that are just strange, but they are not dangerous. We should do everything to avoid physical restraints. And we have all the references for some of these talks. Some of the questions are from the geriatric review syllabus. And I'll be happy to take your questions. Thank you. Thank you for staying till 3 o'clock.
We have a minute or two. Any questions from the remote sites or comments from here? I was just going to say that there was a movie about Alzheimer's disease that this might be really good information for caregivers as well, besides health providers. Because remember the movie Confessions, I think, of a Dutiful Daughter? The caregiver was having a real hard time accepting the fact that this was her mother was giving a lot of wrong information. She didn't know the date, and she thought it was 1979, and just the reaction to that caused a lot of agitation and anxiety with the mother until she realized that she just kind of went with it. Yeah, you're right. It's 1979. That and it was fine. So I don't know if that's in terms of just if that's part of the caregiving training or something like that. In terms of just the acceptance of the information that we get.
I agree. All families, living or taking care of patients with dementia definitely would benefit from attending the caregiver training seminars. Some are organized by the Alzheimer's Association. We have one at UTMB here monthly. Any question from the remote sites?
All right, well, this concludes the sessions. Thank you very much.
Thank you.